Hello, my name is Eric Kaplan. Today I'm going to be talking about traumatic brain injuries, also known as TBIs. So how do we define a TBI? A traumatic brain injury is a broad term that refers to a more specific set of intracranial injuries that are classified by their symptoms, their severity, and the mechanism of injury. So a TBI itself is not a specific diagnosis. You would diagnose something that is on the classification spectrum of a TBI, which ranges from mild to severe. So a common misconception is that TBI and concussion can be used interchangeably when in reality a concussion is actually something that falls under the mild classification on the TBI spectrum. A TBI is any injury to the brain that is caused by a blow to the head from an external force, so it's a very broad term. Some signs and symptoms that you might already be familiar with, like nauseousness, headaches, dizziness, light sensitivity, confusion, disorientation, also known as PTA, which is post-traumatic amnesia, difficulty concentrating, cognitive deficits, coordination issues, and pupil dilation, which is a really common physical sign or symptom that occurs in the acute phase. So these are the more common symptoms and signs that you would see in an individual that's probably still conscious, or you wouldn't really be able to notice a lot of these things. So this would be a mild to moderate case in terms of the signs and symptoms that the individual will be experiencing, and they vary greatly, and they're very difficult to kind of isolate in a patient that's just sustained a TBI because they're invisible to the healthcare provider. You have to really develop a really good communication system with the individual who's just experienced a TBI, or you're not going to be able to develop an accurate diagnosis because these are a lot of signs and symptoms that you'd physically have to ask and get an understanding about from the individual before you understand what's going on with them. So concussions are often classified depending on the number, severity, and duration of these symptoms. And here I've listed the classification system of TBIs. So the Glasgow Coma Score is used and is very significant to the diagnosis process. And it kind of ranks and helps rank the severity of the TBI. And it uses a number system from 3 to 15. So 15 would be the best case scenario, meaning it would be a mild concussion or a TBI, where the individual is still lucid and coherent and kind of knows what's going on. Where 3 would be the worst case scenario, be a very severe case where the individual is completely unresponsive and comatose. So like I said before, if you move over to the right, you can see in a mild case, the loss of consciousness is less than 30 minutes. They score 13 to 15, and their post-traumatic amnesia is less than 24 hours before they start kind of adapting back to normal life again. But in severe cases, the loss of consciousness would be greater than 24 hours. They'd score less than an 8 on the Glasgow score, and their PTA would be more than 7 days. So that's when you're talking about the comatose victims, people who are completely unresponsive, and that would be a very severe case of TBI. A little bit about the epidemiology. It's the leading cause of brain damage in children and adults, so that gives you an indication of how serious of a problem this really is. Even more significant than AIDS, Parkinson's, MS, and breast cancer in terms of its incidence. The greatest number of TBIs occurs in people from 15 to 24, and men suffer twice as many TBIs as women do. Another interesting correlation is low socioeconomic and education status and TBI is something that research is now suggesting. Also, an interesting point, the World Health Organization did a study that suggested that 70 to 90% of cases are classified as mild, and those would be your concussions. So, concussions have kind of made their way into mainstream media as this controversial subject because they're simply happening more than the other cases of TBI. So you're hearing about concussions a lot more because they simply happen at a greater rate. Some influences on the incidence rates. Healthcare professionals are simply more knowledgeable and skilled at diagnosing and assessing concussions and TBIs when they happen. So that's actually going to cause kind of a misleading increase in the incidence rate because it's not necessarily that more concussions are happening, although they may be. It's more suggesting that we're just doing a better job of diagnosing them when they happen. And it's also increasing survival rate and effectiveness of treatment because, like I said before, healthcare providers are just more knowledgeable in their diagnosis and diagnostic efforts. So TBIs, especially concussions, are highly prevalent in the athletic setting. It's where you see a lot of the controversy, especially in the younger population in the sports setting. So you have that culture of risk in sports where you're expected to kind of just brush it off and get back on the field. But when you're experiencing concussion symptoms, that can lead to things like second impact syndrome, where you're causing, really, really serious issues that can even lead to death in some cases. So that culture of risk is a really serious problem, and that's why we have to start educating people more and making people more aware of the risks and some of the other factors that are associated with concussions that have really detrimental effects on people's brains. So increasing use of motor vehicles in the last several decades is another contributing factor, as well as a high incidence rate in the military as a result of everything that's going on overseas and has been going on for the last several decades. So pathophysiology, there's a lot of really complicated neurochemistry going on here, so I'm going to kind of just give you a brief summary. A normal brain consists of neurotransmitter-mediated activation of receptors and subsequent controlled ionic changes in the postsynaptic membrane of neurotransmitter-releasing cells. That's just saying that's what the brain is in equilibrium. Negative 40 to negative 70 millivolts regulated by a sodium potassium ATPase pump. That's, best case scenario. That's a normal healthy brain. Unfortunately, when a TBI occurs, that entire equilibrium is disrupted, and that's where a lot of the negative symptoms come from. So in the acute phase, which is less than an hour after impact, you have a massive influx of glutamate and potassium. Molecules and ions that are really disrupting the normal equilibrium of the brain. And these processes continue out of the acute phase into days and weeks following injury in some circumstances, which leads to eventual degeneration in more severe cases. A little bit more on the pathophysiology. Essentially, it's a disturbance in the ion neurotransmitter equilibrium. And also there's some changes in glucose metabolism in the brain. And that's one of the hallmark signs from a neurochemical standpoint of a TBI is that glucose metabolism change. And the exact mechanism is still not known. The illustration at the bottom kind of describes that ion equilibrium imbalance that I was just describing, gives you a more in-depth illustration and look at what's going on there. There are no known medications at this time that directly treat a TBI. It's such a complex classification of neurological injuries that it's really hard to pinpoint and pin down exactly what they want to be treating in terms of from a pharmaceutical standpoint. So in the acute stage, treatment methods are primarily intended to maintain adequate blood flow, maintain normal blood pressure and vital signs and things like that. But those aren't necessarily medications. They're just treatment methods that are important to keep in mind to keep the person safe in an emergency setting. So in severe cases, norepinephrine is used to maintain blood pressure, and IVs are even more commonly used to combat low blood pressure. So those aren't necessarily medications that are used to help treat TBIs. They're kind of just used to maintain equilibrium in the body in severe cases in the emergency setting. So this is my case study, a little bit on the background. So the patient is a 17-year-old high school football player who was recently knocked unconscious while playing defense during a game. He regained consciousness after 20 to 30 seconds. He had some tingling on one side of his body, but the sensation stopped after several minutes, and then he was transported to a trauma center later on. So for 2 weeks following the diagnosis, the patient experienced nauseousness, dizziness, a lot of those symptoms that we talked about earlier that are associated with concussions, and some infrequent double vision, but those symptoms subsided after a couple of weeks. And he's since been cleared to engage in moderate physical activity, which is something we definitely want to keep in mind. That word moderate is very important. But he does continue to have some balance and coordination issues, so that's going to be another point of emphasis in our eventual exercise prescription. So you can see some of the objective information. He's a very healthy individual. All his his blood pressure, his heart rate, his cholesterol, triglycerides, they all check out. They're very healthy. He's an active individual. He's very involved in sports. So he's, healthy from a physical standpoint. He doesn't have a medical history. So no family history of heart or metabolic disease. So he's a low risk factor in the risk stratification provided by the ACSM. So the goal is to improve aerobic fitness due to several weeks of inactivity, regain balance and motor control, which I said before would be really important, and also to stay asymptomatic and avoid high impact exercise. And I'm going to repeat that asymptomatic part a couple of times throughout, because you really don't want to start exacerbating symptoms, and you don't want to bring back any symptoms that have subsided in the last week or so. So it's really important to keep an eye on that while you're going through this exercise regimen. So here are a couple of the exercise tests that I chose to implement for this particular person. The aerobic endurance test was a mile jog, muscular strength 5 rep leg press max, 1 minute push-up test for endurance, and then I also use a 1 minute sit-up test to further get a gauge of endurance, and the STAR excursion balance test, which is provided by the ACSM in the handbook, and that would be a good test for balance because it's a little more complicated than just a single leg stance test, which I also used with eyes open and closed, so you can compare the two. And then I also have sit and reach test to assess flexibility. So like I said before, testing should be stopped immediately if any TBI related signs or symptoms return. So here's my exercise prescription. I have a warm up and a cool down, which is going to happen every single day. So if he's working out 4 days a week, you're going to do a warm up and a cool down 4 days a week. It's going to be low in intensity, 20 to 30% of HR max. And it can consist of anything from some light swimming, doing some lap swimming, very casually, to just some light jogging. Or using the stationary bike because it's low impact and you don't have a risk of, sustaining another head injury, of course. Aerobic exercise can be 4 days a week, 40 to 60% of heart rate max. You kind of want to keep it in that moderate intensity area. And they can consist of lap swimming, using the rowing machine, some light jogging if it's comfortable. So, like I said, stationary bike is definitely ideal over a normal bike to avoid accidents. And that should last from, around 40 minutes or so. So resistance exercise can be done in conjunction with both of those, the previously stated regimens. It can be, a little bit more intense, maybe, probably moderate intensity. Like that's as far as you want to go in terms of intensity. So you want to keep that in 30 to 50% of the 1 rep max if you are using weights. I kind of wanted to err on the side of caution and use dumbbells and tubing, maybe not even dumbbells if it's not necessary, just to be a little bit safer and a little lower impact. So high repetition if he's doing things like that. Lower weight, definitely on the lower side of resistance. You don't want to be exerting too much in these early stages of exercise. And you want to use a combination of muscle groups on designated days and not repeat them in the same week. So you kind of want to gradually integrate these things without exacerbating symptoms and without, bringing symptoms back. So resistance training, you definitely want to keep an eye on that, and it can be done 40 to 60 minutes, 3 days a week. So a little less frequent than aerobic exercises. Balance exercises are really important, and I listed a couple of examples. So you want to stay on the moderate side of intensity and do it as it's comfortable to the individual. You don't want to start bringing him too far out of his comfort zone where he could get unstable and end up falling and hurting himself again, especially hitting his head would be the major concern. So, lots of work on the stability ball, the Bosu ball, doing single leg stance and things like that, where we're going to be really focusing on balance and getting that balance and coordination back so we can get to a more normal level and hopefully get back onto the field eventually. So that's kind of as tolerated. You want to get a good gauge from the patient, what he's comfortable with. So 3 sets, 12 to 15 rep format. And you want to do that maybe 4 days a week along with the aerobic exercise, which is also going to be 4 days a week. So flexibility, pretty straightforward. Static stretches can be completed after exercise, and dynamic stretches before exercise. You want to do this every time that you work out. And I'm going to have them do that for 5 minutes, dynamic and static, before and after. So you can do anything from lunging with a twist, doing trunk rotation, just simple flexibility exercises like that. Some special considerations while he's exercising. If there are any symptoms that were present just after the TBI, diagnosis returns, exercise must be stopped immediately. So if he's having any symptoms, any sign, you got to stop immediately. It's a point of emphasis I'm making because you really don't want to make matters worse when you're trying to make matters better for this person. So all exercise sessions should be monitored very closely and spotted appropriately. So, this isn't really a situation, especially because he's a little bit younger, where you'd want to send him off on his own in the early stages. You really want to make sure that he's safe and make sure that the individual, especially doing balance exercise where he's on an unstable surface, make sure that he has a spotter and someone that can really keep an eye on his stability, because stability and muscle coordination was such a concern. So these are my references here. Lots of lots of professional journal articles kind of allowed me to formulate this presentation. I hope this gives you a good idea of what traumatic brain injuries are, what concussions are, to a little bit of a higher degree than maybe you were aware of before. And I hope that this kind of helps to raise awareness, like we were talking about before, and we can actively work to lower the incidence of TBIs in society. Thank you.